start. Welcome everyone to today's EU-JAMRAI meeting on the Urban Wastewater Directive's potential impact on access to antibiotics. We are going to start with some Menti questions, so you'll get the code for that in a second. But it's our great pleasure to have Dr. Bastiaan van Heus here, Senior Policy Officer, Director of Medicines and Medical Technology, Ministry of Health, Welfare and Sport from the Netherlands. He's going to start off with a 15 to 20-minute presentation on the regulations, cost and impact, and that will be followed by Luca Prodicimo from the Medicines for Europe. So we're very pleased that Luca can also join us, and he's going to give us perspectives from the generic pharmaceutical industry for also 15 to 20 minutes. Then we should have time for questions and answers. So save your questions till the end. We should have plenty of time to go through those. And then at the very end, we'll have a Menti question just to see what you think. So we will start here with the Menti. So hopefully it should work for everyone.
I'm sharing my screen.
Oh, good. Thank you, Signe, for taking over. I appreciate it.
And we'll take the next slide. Right, Christine?
Yeah, that sounds good.
And next.
For those of you just joining us, we're just doing a brief Menti, so we just have 2 questions left, sorry.
And we'll take the next one.
Maybe we go to the next one.
Yeah. And now I'll end the presentation, stop sharing, and give it over to you, Christine.
Thanks so much, Signe, and it's over to you, Bastiaan.
Thank you, Christine. Thank you for introducing me, for giving us the opportunity to talk about the Urban Wastewater Treatment Directive and the impact it potentially has on the medicines supply. Thank you for the audience for joining this webinar. I see that we're closing in on the 100 attendance, which is very nice to see such great numbers. I see Christine also beaming, so that's you did a good job, I think, with sharing and the invitations. Wonderful. Well, first off, we thought we'd start with the Mentimeter, just to see what kind of crowd we would have in the audience, and to see well, if you heard about this before, and it gives me the opportunity to dwell a bit more and a bit less on some of these slides. So I'll start the presentation right now and take you through the first part of the webinar. Is it shared or is it not shared?
Not yet.
Not yet, okay.
Perfect.
Yeah,
Thank
you
you.
see it? All right, wonderful. Let's see. All right, well, thank you again for inviting us to this webinar. We're delighted to talk about the subject. It's about the extended producer responsibility, which is part of the Urban Wastewater Treatment Directive. And it applies to pharmaceuticals and cosmetics, but I'll be talking about pharmaceuticals only. Cosmetics is another business, and it's not something I'm acquainted with. And so let's start with the next slide. Yeah, next slide. Okay. First of all, some background. You may be aware of pharmaceuticals being increasingly in the scope of the environmental legislations. And I listed a number of examples here. There's obviously the Urban Wastewater Treatment Directive, but there's many others. And some are more into the pharma, some are more in the medical devices. Some are about climate impact, some are about medicines residues, and today we're talking about medicines residues. And I'd like to point out one particular one because we're talking about antibiotics, and that is the priority substances regulation. This is a regulation about substances, pollutants in water, and every now and then there's an update of a list, which is called the priority list, and the new version features 3 antibiotics, and these are accompanied with a maximum concentration in water, and we'll talk about that a bit more. For the Netherlands, the outpatient antibiotic use last year. What you see here is the intake of 4 antibiotics in kilograms, and underneath is what we excrete into the toilet. So either urine or feces, it's mostly urine. Unchanged API will be excreted. And for amoxicillin, which is the largest use in kilograms, we have an intake of about 20 tons a year in the Netherlands, and that 14 tons is excreted and changed. Well, you can read the table to the right for yourself. But I'd like to point out that azithromycin and clarithromycin, the surface water concentrations of these two sometimes exceed the risk threshold in the Netherlands. That means that the actual concentration exceeds the predicted no effect concentration. So that means that something needs to be done, and I have to tell you also that it's not continuously exceeding, but there are measurements where they are exceeding the threshold. So the reason that we are pointing this out is this is why the European Union listed these three substances, the three mycin antibiotics, under the priority substances list. Now, why do I mention this? Because this list is also connected to the Urban Wastewater Treatment Directive, and I'll tell you more about that on the next slide. But first, let us take you through the water quality. You may notice, or you may not be acquainted with this, but bear with me. Most important thing to, I think we should start at the bottom row where the arrows are. On the left-hand side, you see a medication. You take the medication, and after a while, you go to the lavatory, and the medicine's residues are flushed through the toilet, goes through the piping to the wastewater treatment plant. The wastewater treatment plant, and of which you see an example in the photograph, does its work, and then the treated wastewater is going into the surface water, and that's where it will meet fish and all other aquatic life. Well, the wastewater treatment plant, it does its thing, and it's an organic treatment facility, and it's essentially built to remove normal excreta from wastewater, so that these feces and urine. It's not designed to remove medicine's residues. And overall, we see that the removal rates for pollutants, micropollutants, as well as for nitrogen and phosphorus are insufficient. That means that the treated wastewater is not really clean enough. And because it's not really clean enough, it means that this is a threat to the surface water where the treated wastewater is going. And as a consequence, it also is a threat to the quality of groundwater and drinking water. In the Netherlands, we make a lot of drinking water from surface water. So for us, it's really relevant. So the idea is, do we need a fourth stage of purification after the wastewater treatment plant to increase the removal rate for the pollutants that are not yet sufficiently removed? So, and here the Urban Wastewater Treatment Directive comes into play. In the revised version, the directive lays out that the removal rate should be above 80% for medicines residues. At present in the Netherlands, it's about an average of 60%. So it could be 100, it could be 0, but on average, it's about 60. And that we need to crank it up to over 80. So it's at least 80. And the means to achieve that is to install additional purification, which is called a fourth stage purification. And the idea is that large wastewater treatment plants will be extended, have the additional purification, but also maybe some smaller treatment plants which are connected to vulnerable ecosystems. And the directive also lays out that it should be financed through a extended producer responsibility. And this is in the environmental world a very normal way of making sure that the bill is paid and that it motivates producers to become greener and well, save on public expenses, basically. So what should the producers in this case be financing? First of all, the construction and the exploitation of the fourth stage facilities. Then they have to make a national producer organization, and they should collect and monitor and verify data and make sure that the right amount of money is paid by the right person and paid to the water boards. In the Netherlands, it's called water boards. And then there's also all sort of other costs. So this is a financial EPR. And this goes back to the polluter pays principle. So by making the polluter pay through an EPR, it is, like I said, an incentive for producers to reduce pollution after use. It should also be an incentive to develop greener products, and it should save on public expenses. In this case, it's a challenge because medicines use will more likely increase than decrease because our society is aging. So we don't see much room for less medicines. And at the same time, the cost for industry will automatically increase the public expenses on healthcare. So what we save on the environment will be on the budget of healthcare. So this is a challenge. We need to find a way to do that. The other challenge is, and that's where I'm going also more directed to the antibiotics, greener medicines in general are not in the patient's best interest, because in general, a greener medicine requires a higher dose or a more frequent dose or more invasive administration. So for instance, instead of oral administration, you might need a subcutaneous dosing. And suppose you have a headache, it's not in the patient's best interest to switch from an oral formulation to a subcutaneous injection. But I'd like to illustrate that with an example. This is one of an antibiotic, and the researchers thought, okay, can we not make this greener? So they started with ciprofloxacin, and I'm sorry for the structures if you're not familiar with reading chemical structures. I love chemical structures, so I'm always seeking an opportunity to incorporate them. So there you have it. On the left hand, the ciprofloxacin. On the right hand, the more green alternative, the hemi. Well, the advantage of the molecule on the right is that it has a lower risk, lower environmental risk at the same dose, which is due to the greenish area. It's more labile. However, it needs a higher dose because it's less effective. And here comes the twist: a higher dose, and I'm talking about a really higher dose. This is ciprofloxacin has a daily dose of 1 gram a day, and the one on the right has probably more than 10 grams a day. So this is significant, which means increased patient burden. It also means that you need more raw materials, energy, and water to make this product, and you create more waste. Also more medicines residues. And because you take more kilograms and you create more kilograms of waste, you in the end don't know what this does to your EPR costs, because more waste might mean more costs. So this is the challenge in making greener antibiotics. You're not certain if this will help the situation or not. So which medicines are included? Well, some medicines are not in the scope because they are excluded from pharma regulation, the general pharma regulation. And we need to still talk about that because it's not clear if they are going to be included, which one is going to be excluded automatically or included. Because here's an escape route. For instance, the magistral formula is one of the items which is out of scope for the Urban Wastewater Treatment Directive. But if you leave it out of scope, then there is an incentive for producers to make more magistral formulas and to do less registered medicines. So we still need to think about how to fix that, how we go about this. And there's some other products as well which are out of scope. But you might have medicines which are included in the EPR, but may receive an exemption. For instance, if the quantity of the substance is below 1 ton. The 1 ton is the total weight of the product, as we understand. So if you would have 1 liter of water with 1 microgram of API, the 1 liter will count. That's our understanding, at least. But anyway, if you're below the 1 ton, this is you can apply for an exemption. This will be quite challenging if there's no central register in Europe of really small market products, because then you have to see what's going on in every country and then see if you come above the 1 ton. Another reason why you might receive an exemption if it's readily biodegradable and it does not generate micropollutants in wastewaters. What exactly is readily degradable is not yet defined. In addition, micropollutants is not yet clearly defined, and as well as what end of their life is. That's also not certain. So we're still in the process of understanding what the legislation means. So we have many, many questions. So about the cost, splitting the bill. First of all, I made a bar of which consists of 80% or 20%. The legislation says that producers should contribute at least 80% of the total bill. And the governments obviously may contribute 20% of the total bill. But within the 80%, it is not yet sure what how much the cosmetics have to pay and how much pharma has to pay, because we don't know yet which substances have to pay what. What we do know is that the initial estimate for the Netherlands for the total cost was 65 million euros per year. And the current or last year's estimate was that it's at least over 400 million. And next year we'll do a formal review again of what the number is, but it's considerably higher than initially estimated. And at present we have no idea where the costs are landing. And what I do like to mention is that the legislation is set up in a way that the costs will never go away. So if one product or one area is becoming greener, like cosmetics, of course it's easier to reformulate cosmetics than reformulation of pharmaceuticals. So let's assume cosmetics become greener, then the cost for pharma will increase. And if you're the last pharmaceutical producer in that brings something to the market which generates micropollutants, then you pay everything. So the contribution will be based on the quantities and on hazardousness. And if we look at quantities, then this is what you get. This is just quantities, not hazardousness. This is the Dutch top 100 prescribed APIs in kilograms, and then, well, the top 6 are written in text, and you see that there's many tons of macrogol, metformin, psyllium seeds, lactulose, and paracetamol. So these are prescribed. This is not over the counter. And the first antibiotic in this list that is amoxicillin, and it's I think in position number 12, somewhere around there. So it, based on kilograms, it does not have to pay a lot. However, we've not yet accounted for the term hazardousness. And this is going to be really important, in particular for antibiotics, because hazardousness will largely determine how much the contribution will be. And as I said in the introduction, we already see that some antibiotics exceed the risk threshold concentrations in surface water. So we can assume that there will be the hazardousness level for antibiotics will be larger than for, well, middle of the road medicines. But what exactly will be hazardousness will be set out by the Commission in a guidance, and that we have to wait for this guidance until the end of 2027. So in the meantime, we're not sure what this is or what the impact is. As a matter of fact, we need to have our legislation ready mid-2027. So we have to have our legislation, the implementation ready even before we fully understand what hazardousness means. Which actually means that the impact probably will be on antibiotics will probably be known in 2028, something like that. Unfortunately, we can't speed it up. Let's see. I think I should thank you now for your attention and turn it over to Luca. Thank you very much.
Thank you, Bastian. That was very enlightening. Luca, do you want to share your presentation? And then when Luca's done, we will open it up for question and answer.
Of course. Thank you very much. Thank you very much, Christine, and good morning to everyone. So thank you again for organizing this webinar and inviting Medicines for Europe to speak. And many thanks to Bastian for the excellent presentation, as always. So maybe, can you see my slides?
Perfectly, thank you.
Thank you so much. So just quickly about Medicines for Europe, we are the association of the generic, biosimilar, and value-added medicines manufacturers across Europe. So our membership includes both over 60 companies as well as national associations from 21 EU member states, as well as Switzerland, Norway, and the United Kingdom. And the off-patent sector, as you, of course, may be well aware of, provides 7 out of 10 dispensed medicines and 9 out of 10 critical medicines in Europe, while also, of course, being an important asset for EU manufacturing and also in terms of economic growth, thanks to almost 200,000 people being employed by the sector at over 400 manufacturing sites in Europe. So when we talk about antibiotics, of course, we are already talking about a vulnerable market. This infographic that was developed by our Friends Association a couple of years ago shows how, for instance, in France, the cost of one week of treatment with antibiotics can be lower than the price that you paid for one coffee. And of course, this is not only the case of France, but we believe it's a very representative image, unfortunately. There was also a very interesting study published recently by New Angle, looking at the situation in the last 4 years. Of course, manufacturers had to deal with increasing inflation, increasing producer costs, cost of goods, including packaging, not to mention, of course, skyrocketing energy prices, so both in terms of gas and electricity. So all, of course, these costs were increasing. At the same time, we can see by analyzing the top 10 most used off-patent antibiotics across 16 countries in Europe, we can see that the prices are 10% lower in 2024 than what they were in 2020. Of course, this then leads to problems with security of supply, so with forced withdrawals, of course, then increasing the risk of shortages and the actual occurrence of shortages. So it's already a very delicate and fragile market. And this is not only the case for antibiotics, it's also the same for several other generic products. Indeed, the sector is already facing some serious challenges in terms of economic sustainability. At the same time, the sector is very active to address the challenge that Bastian was also mentioning related to the presence of pharmaceutical residues in the environment. So the off-patent sector is working closely with also the originator industry and with the self-care industry on nicopharmaco stewardship that has been going on for years. So with concrete proposals to refine the environmental risk assessment, which is already been also reviewed in the pharmaceutical legislation revision, the development also of guidance on responsible management of manufacturing effluents, and also awareness campaigns like med disposal on the appropriate use of medicines, storage, and disposal. At the same time, Medicines for Europe is also a board member of the AMR Industry Alliance, and so we have played our role in helping to develop standards on antibiotic manufacturing that actually Medicines for Europe companies have to respect in order to be members of Medicines for Europe. So the sector is very active when it comes to try and, let's say, decrease its environmental footprint, with a particular attention to manufacturing emissions. However, the extended producer responsibility system in the Urban Wastewater Treatment Directive is not really about this issue, which is already quite well controlled in Europe, and again, the industry is even going beyond the legislative requirements to develop stricter standards. However, here we're really talking about, in the case of the Wastewater Treatment Directive, we're talking about pharmaceutical residues that are present in wastewater after patient consumption. Of course, the patient has to take the medicine, and as Bastian was mentioning earlier, a part of it, in many cases, is excreted and then reaches the wastewater. So I think we've been quite vocal over the years and also recently with regarding our concerns with the system of the Urban Wastewater Treatment Directive. First of all, there is this focus only on human medicines and cosmetics, which is quite puzzling because it ignores the presence of several other chemicals in wastewater, from pesticides, biocides, household products like detergents, food ingredients and additives, industrial chemicals, even veterinary medicines. The list is quite long. Of course, it's quite difficult. according to some experts, basically impossible to assign a specific share of toxic load in wastewater to a certain sector. The decision to target pharmaceuticals and cosmetics was based on this, let's say, claim that these two sectors combined represent 92% of the toxic load in wastewater. However, after some request for access to documents, we could also see the data that were used by the consultancy that produced that worked on the feasibility study for the extended producer responsibility system, and we can see that there are some problems with this list of pollutants that was used to assign the different shares of pollution to the different sectors. So, for instance, we saw that 4 medicines were considered to be 58% of the entire toxic load across all sectors, which is again quite puzzling. One product, one substance, telmisartan, which is also usually not considered a particularly problematic molecule for substance for the environment, was considered 41% of the entire toxic load of all sectors across over 1,000 substances. So this really led to a massive overestimate of the toxic load that can be attributed to pharmaceuticals. This seems to be really due to the use in some cases of in silico models for the calculation of the predicted no effect concentration that inflated ecotoxicity. If we use instead the laboratory, the empirical PNEX that are also the only one accepted by the EMA, we can see that, for instance, for these 4 substances, the toxic load share drops from 58% to below 1%. Then also the system is, if you read the impact assessment, the feasibility study, there is this assumption that the cost can just be transferred on to, in this case, to patients, or that the industry can just absorb this cost in its margins. However, this really doesn't take into account the strictly regulated pricing and reimbursement systems for pharmaceuticals, the narrow margins of especially generic medicines. And also there is this assumption that EPR will help develop, will foster, let's say, the development of greener medicines. I think Bastiano already covered extensively the challenge linked with this idea. So basically EPR here is mainly a finance, let's say in the case of pharmaceuticals, only a financing tool to fund this additional wastewater treatment with no steering effect. So we try to model the impact of EPR. So together with IQVIA, taking into account the original estimates from the European Commission, 1.2 billion per year. Then there is also a breakdown for each member state. So we use the Commission numbers, and we also use, in some cases, the projections that we are seeing, for instance, from the Netherlands, 6 times higher than what the Commission had foreseen for the country. In Germany, we can see that the environmental agency is, let's say, shared cost estimates that are 4 times higher than what the Commission had said, and even the water industry is foreseeing much higher costs. So also something that needs to be taken into account. So how we try to develop the models on the impact by basically following the wording of the legislation. So as it was mentioned before, EPR fees should be modulated based on quantities and hazardousness. Hazardousness indeed is a huge question mark at this point. For the purposes of our exercise, we developed one model just based on the mass, so the volumes of the APIs. One model that is that takes into account the mass, but then also weighted by the PNEC, so the predicted no effect concentration, which is also the indicator that the Commission used for the impact assessment. However, there are challenges because in some cases for legacy products, for instance, PNECs may not be available. And also we developed a third scenario, which is really a 50-50 combination of the two. What is really interesting to see, probably not a surprise also considering that generics represent the highest volumes of medicines in Europe, is that under every model, so mass only, PNEC weighted 50-50, generic generics would represent around 60% of the fees that have to be paid by the pharmaceutical sector, which clearly is unsustainable, considering that the off-patent sector represents only 19% of the market value. So asking the sector to pay 60% of the fees is clearly disproportionate and unsustainable. We also try to develop a model on the impact on specific molecules. It's indeed very challenging because of all the uncertainties with the current system, since the legislation is quite vague in many parts. However, for instance, the mass model was probably a little bit more straightforward. You can see that there are some differences, perhaps compared to what Bastian showed. So again, there's a lot of uncertainty for this model. We assume that certain products may be exempted because they're readily biodegradable, but of course this will need to be proven. And in our model, under a mass-only scenario allocation, metformin would be the substance that is going to be affected the most. You can see even this is using the conservative estimates from the Commission for the total cost of quaternary treatment. Metformin would have costs of potentially over 250 million, so clearly unsustainable. And other therapeutic areas would also be affected. And you can see that in this model, amoxicillin would rank third, actually, because in terms of fees, because of its very high volumes sold on the market. And then you can see really that the fees would be really concentrated on about 20 molecules. And we can see the same trend also with the PINEC-weighted model. The difference is that the molecules in most cases change because this model takes into account then the ecotoxicity. So you can see that other products like metamizole, for instance, would be particularly affected. But also in this list, you can see among the top 20, ciprofloxacin ranking 15th, so showing that also under this kind of allocation key, certain antibiotics could be massively affected, not to mention other therapy areas that you can see listed. Also, the problem with this EPR system is that there is no easy fix, in our opinion, because even sometimes we hear maybe suggestions to exempt certain medicines, perhaps exempt medicines on the critical on the EU critical medicines list. Unfortunately, this would not work because the cost would then just be shifted to other medicines, making them unviable in turn. So it's really a vicious circle because at the end, the pharmaceutical sector always have, let's say, to pay this total bill linked to wastewater treatment. So in the end, some products would still have to pay and would therefore become most likely economically unviable. So you can see that we developed models also for Germany and for the Netherlands. You can see that in Germany, even with the Commission estimates, the impact for amoxicillin under a mass model would be around 27% of the total sales. For the Netherlands, we are also able to include ciprofloxacin. So we compared basically the expenditure for that product, both in the Netherlands, in this case in the Netherlands, with the potential fees for the product. And you can see that, again, under a mass model, amoxicillin would be massively affected. Under the Dutch government national estimates, it would be over 350%. The fees would be over 350% of the current expenditure for amoxicillin. You can see that with a PINEC model for ciprofloxacin, the impact would be over 1,000 of the expenditure for that product. So I think we already saw what are the key takeaways. In our opinion, there is no model that would be sustainable for the generic sector. Under any possible allocation key, certain antibiotics would be affected. So we're really facing huge risks of certain essential medicines becoming economically unviable, leading to major supply disruptions. So just to finish, our call for action is really to review this legislation, much earlier, right now, much earlier, of course, than the 2033 deadline in the present legislation. Industry will have to start contributing between 2028 and 2029. So, of course, companies are already starting to look at their portfolios, even though there is a lot of uncertainty. We believe that there is the need to pause the implementation process and to review the impact assessment to take into account also these divergent estimates on the cost of quaternary treatment, the impact on the affordability and availability of medicines, on which both the Parliament and the Council have already expressed several concerns. Also, it would be good to look again at the toxic load of the different sectors, given the concerns with the data that I mentioned before. And in the end, we believe that this should really lead to an urgent review of the legislation to protect the supply of medicines and patient access. And again, ideally by the end of 2025 or the beginning of 2026, as national discussions have already started, and there is really the need to provide clarity to all actors involved, but also ensure that the EPR system or the Urban Wastewater Treatment Directive doesn't really lead to supply disruptions and problems with access to off-patent medicines. Thank you.
Oh, thank you so much, Luca. Thank you. That was wonderful.